Next, we got Caitlin Brooks, who is the Physical Activity Clinical Coordinator for South West Sydney Local Health District. And Annie Saffrett, who is the Occupational Therapist Clinical Educator, also for South West Sydney Local Health District. When we are talking about enhancing falls assessment and prevention in South Western Sydney Local Health District, and say that properly, Transitional Aged Care Program, TACP. There we go.
Good afternoon, everyone. My name is Annie. I am, like they said, the Occupational Therapy Clinical Educator for South Western Sydney Transitional Aged Care Program. And this is my colleague, Caitlin Brooks, that's the Physio Educator. So today we'll be presenting on our big quality improvement project on enhancing falls assessment and management in our TACP service. So we're part of a very large project team. So we're really appreciative to be able to present that today.
So before we get into our actual project, we thought we'd just give a quick background on what TACP is. So can I get a quick raise of hands who here is familiar with TACP? Okay, good, most people. For those of you who don't know, it's a community-based multidisciplinary team. So we provide therapy and support to older adults who are transitioning home after hospital. Our program goes for up to 12 weeks, but the exact duration depends on what the person's goals are and also how they're progressing once they get home. So in South West Sydney, we have 5 community sites and we also have 1 residential site spread across the district. The clients that we see on TACP do vary quite significantly, but one consistent is that most of our clients have either had a fall or are at risk of having a fall. So we went to explore this problem a little bit more last year, and in an audit we conducted, we found that 46% of the clients on the program had had a fall that was causing their admission to hospital, and 79% of our clients had had a fall in the past 12 months. So falls really is kind of core business for us in TACP. Now, despite this though, we did find that across all of our different teams in South West Sydney, no 2 teams sort of assessed or managed falls in a consistent way. So that meant that a client on TACP at, say, Bankstown could be managed very differently to a client at the Liverpool team. So this kind of got us starting thinking that maybe this is something we could enhance, and this is where our project came into play. Lucky for us, this was also around the time that the new falls guidelines came out last year, so we were able to link this project to aligning our practice with evidence recommendations and then also making sure it was more consistent across teams. Because that is a quite big, broad topic, we've gone with the improvement science methodology to help sort of narrow what we're doing for this project. This is our driver diagram. Does this image look familiar to people? Can I see a raise of hands if you've seen one of these? Not as many people. Okay, I'll quickly talk through what it is. So this is just basically our project on a page, and it is in the very early stages, but what we have is at the top our project team. So we do have representation from most of our community sites and also most of the disciplines that we have. That first blue box is our goal, and that's around aligning practice with evidence and then also making it more consistent across teams. The purple and red are our primary and secondary drivers, so they're the big factors we're going to have to influence in order to make a change. And that last row on the end there are all the different change ideas that we've thought of. So while we would love to talk about all of these change ideas today, for sake of time, Annie's going to run us through 2 of the key ones that we've done.
Thank you, Caitlin. So one of the major challenges that we had identified, that there was a varying accuracy of reporting of falls across our district. Like Caitlin was mentioning about our management, we also were reporting them inaccurately. So it meant that we were having incorrect data to be able to start with, and trying to determine the scope of falls within our service as a whole. So that was one of the change ideas we instigated, a PDSA cycle, and we tried to look for existing policies and procedures in our district around the reporting procedures for falls. And unfortunately, a lot of the directives were very inpatient focused and didn't have any community examples. So that was really limiting for us. So we then decided to take the existing policy and create some community-specific scenarios that was really relevant to us and across multiple of our teams, not just TACP as well. And then we were able to get some feedback and support from our management, the team leaders across our district falls steering committee, and the Director of Safety and Quality under the directorate that we're under. So that level of support then created this new guide that we now have. And so we're now in the implementation phase with this particular document, and we've got some pretty good feedback at the moment around the clarity around falls reporting. So that was one PDSA cycle. So we wanted to share another change idea within our project that had multiple PDSA cycles, so depicted here as a PDSA ramp. So following on from the falls reporting guide within our service, we now know when to report a fall, but then had very limited consistency again from what to do from a clinical perspective with regard to post-fall management. So again, unfortunately, within Southwest and Sydney at the time, there was no formal post-fall management for community. So we had to kind of look outside of our district. So we came up with another form from another district, which we trialled in one of our teams. And we quickly realised that it was not quite appropriate for our context or for our teams. And so then we made some changes to the form. It was trialled again in some of our teams as well for some falls, and that was positive, but we had some feedback, and the feedback was that they wanted to make it easier to actually use in the community, and also that it could be made interdisciplinary. I guess one of the things in TACP is that we have a big multidisciplinary team, and a patient can report a fall to any member of the MDT. So it was really important that the information that we collected wasn't just physio or OT specific. So with that, now we have our final, hopefully, form, which we are trialling and implementing, and we'll take on some feedback and hopefully have it as a formal form. So we've had some, data around that too, which has been really positive. So we've had, obviously, this commitment to improvement and effective feedback, which allowed us to create this form that was easy to use, accessible in the community, as well as interdisciplinary. So in January, when we first implemented the checklist, only 40% of falls on TACP had any documented evidence of the post-fall checklist. And at our recent audit in April, with all the various changes and improvements that we made, we had 90% of falls on TACP that had the checklist actually completed now. So we're really happy with the improvement and the uptake of this particular form. We hope that continues. So we're going to continue to monitor this in our next implementation phase. So now Caitlin's going to talk about some reflections.
Yeah, so we just wanted to end with a few key reflections that we've had, just in case anyone out there is working on like a similar kind of project. I guess we have had a number of challenges with this project. The first of them being that we're working across multiple different sites and also multiple different disciplines. So they all kind of have their own ways of working. And so implementing change across multiple teams is quite a challenge. What's been really helpful for us is the fact that we've had a really big project team that's representative of all those different smaller teams. And that's meant that in our planning meetings, we have kind of representatives from those teams who can share their opinions, but also then when we're trying to implement change, we've had key people at each site who've been able to push that change forward and make sure we've actually had success with them. So that's been really helpful. One of the other challenges that Annie touched on was that a lot of the existing resources in our district were kind of inpatient focused and there wasn't a lot specific for community. So we have had to make a lot of this up from scratch. What's really helped with this has been getting that external support and endorsement from people outside TACP. So like Annie mentioned, the Falls Steering Committee, the Falls Prevention Coordinator and those kind of people, they've been able to make sure that we've kind of kept our project jack within the scope of what the district's doing and aligning it with that practice, but also giving us some objective feedback as well to help kind of guide what we're doing. I think the other big thing as well is because there wasn't a lot, we really could have gone anywhere with this project. And I think using that improvement science methodology has helped guide us to the things that are going to give us the most bang for our buck and make sure we're working on like the priority areas has been really helpful. The last bit on there is just around the interpreting guidelines, which is just more around the time that it takes to be able to kind of go through those new guidelines, decide what's most relevant for us, then audit our practice against it. It just takes a lot of time to do all of that. Something that we found really useful was utilising students, and some of our project students came on board to help kind of do a lot of that groundwork. And that meant that when our clinicians kind of got involved, we could really hit the ground running with some of our change ideas. And it's meant that we've been able to move forward in quite a short amount of time and made some really good progress.
So I just wanted to add on top of that is that we've added some posters here. Something that we really noticed, like Caitlin was saying, is that this project has allowed so many opportunities for all of our team members. We probably haven't tackled such a big quality improvement project in TACP before. And so we know that there's so many different things happening all at once. And so here are some examples of some of the scientific posters that we've had students create and the multidisciplinary team. And I think that kind of leads to our whole team. You know, we're very, small cogs in a very big wheel. We have a lot of people working on this, and we're really grateful for how well the project has been going. And I think, like Caitlin was saying too, that our consultation and endorsement from other people around our district has been really helpful, and they've been incredibly supportive of us. So thank you for having us.
Thanks, Annie and Caitlin. All right, any questions? We have a minute or two. Yep, one at the back, Polly.
I'm just kind of wondering if other community teams are taking what you've started on board. Like I'm thinking about, community lung services and heart services and things that obviously we're seeing falls in those areas as well. Has there been interest that you're picking up on other teams in the area?
We haven't really expanded too much yet. We've mostly been working within TACP. We have started to expand some of them, like their falls reporting guidelines, to like some of the other ones in our directorate, so they're aging well, but we haven't gone out further than that. But I think we'd kind of want to get it kind of working for us first, and then we'll kind of expand it a bit more after that, hopefully. Anything else?
All the way on the other side. Get your
Steps up, yeah.
That's good for you.
Hi, my question is actually going back to your question. We are from local government, and we are an amalgamated local government. Our issue is that these programs are fantastic. For an 80-year-old nana that lives on one side that you don't cover, doesn't understand that her best friend is getting the treatment that you're providing. So have you kept in mind that some of the local health districts don't cover the same local government areas? I'm from Canterbury Bankstown, and we are facing that with my colleague here. We have to do double the whammy of services to make sure that we're covering all of our residents. And we have over 80,000 seniors 60 plus, and they don't understand local government division. Local health district divisions. So it'd be great to keep that in mind. I'm not sure how are you doing that. Thank you for that question.
Yeah, I think that's a great point, and I think we experienced that a lot, particularly on our northern end, so our Bankstown end, where people might have gone to one hospital accessing TACP from our community program. I think it's a huge thing. I think that's why within Southwestern Sydney and Sydney we have a lot of joint clinical networking groups. So I think that's a really good point for us to take on, and once we have really got this project underway, is to take it to those networking groups so that it can be across those really annoying street boundaries. Yeah. So no, thank you for that. Yeah. And it's really important. Yeah.
Thank you very much. That's all we have time for. Great to see passionate clinicians leading this work and doing the evaluation too. So thank you very much.